afternoon, friends. On behalf of the Indian Society of Oral Implantologists, I welcome. Good afternoon, friends. On behalf of the Indian Society of Oral Implantologists, I welcome you all to the third webinar in the Learn from Home series of continuing dental education, hosted under the auspices of ISOI. Today's speaker is none other than the very much sought after, flamboyant Dr. Sudhindra Kulkarni. Dr. Sudhindra, take a bow for agreeing to regale us with your presentation at the 11th hour. Though Dr. Sudhindra does not need any introduction, let me speak a few words about him. Dr. Sudhindra Kulkarni has done his MDS in periodontology. He is the diplomat of ICOI USA and he is the professor and head of the Department of Implantology and professor in the Department of Periodontics, SDM College of Dental Sciences and Hospital, Dharwad. He has a private practice at Hubli with experience of 19 years. He is a clinician par excellence. He is very active on both national and international lecture circuits. He has numerous presentations and publications to his credit. Friends, I present to you Dr. Sudhindra Kulkarni.
Very good afternoon, everyone, and thank you, Dr. Himanshu Mehta, sir, Dr. Paresh Kale, Dr. Uday, and the entire office bearers of the Indian Society of Oral Implantologists, the ISOI, for coming up with such a wonderful platform where we all can sit and learn right from our own bedrooms rather. It's indeed an honor and a privilege to speak for the Isoi Study Forum. And this is my first Facebook Live. And we should also thank Mark Zuckerberg for making the technology so wonderful so that we can learn, especially in these such tough times. Also, a very warm welcome to all the members of the ISOI and everyone else who's logged into this program. Let's start without much of ado. Let's start with the session on what we call as the sinus bone graft. The sinus bone grafts, though, have been done for ages right now in the current era. However, a lot of questions keep on coming up even in the mind of someone like me who's been doing sinuses for probably last 14-15 years. And let's try and see how we can sort out the small doubts what every one of us comes through on a day-to-day basis in our practices. So the agenda for today would be, let's try and understand why we need to do a sinus graft. We will then evaluate the sinuses, how they appear on a radiograph. Very importantly, let's see the relationship of the roots of the maxillary teeth in relation to the sinuses, some pathologies, then the various direct sinus graft procedures. We'll also do a small debate on whether we graft or not, use a material into the sinus or not. Let's understand some complications that can happen and also evaluate the outcomes that can happen with the sinus grafting procedures. And today we are primarily dealing with the direct sinus graft or the lateral window approach. The indirect sinus graft will not be covered. Let's understand foremost, very importantly, is the anatomy of the maxillary sinus. When you look at this picture, you can see that there is a maxillary root, and then you have basically the lateral wall of the sinus. The lateral wall is where all the procedures are done, especially to get access into the sinus. However, the floor as well as the nasal wall of the sinus are also very important when it comes to getting the necessary cells into making the graft or material, whatever we put into the sinus, to convert into the bone. When we look at it from a proximal view, we look at it from basically four walls. One is the lateral wall, then is the apical wall that's far above. The apical wall of the sinus is nothing but the roof of where the osteotomy sites are there. And then you have the medial wall, which is nothing but the nasal side. And there's the anteromedial wall, which is more in relation to the anterior part of the maxilla. Let's look at this picture. Yeah, the number 2 is the anteromedial wall, which we rarely touch. The critical areas are what we call as number 1, that's the lateral wall. Then is the inferior wall, is nothing but the floor of the sinus. 3 is the medial wall or the nasal wall. Posterior wall is number 4, where we would rather not look going so back. And then a superior wall is nothing but the lower border of the orbit. Now, from our point of view, the most important areas would be points number 1, number 5, and number 3. And we look at managing these 3 areas. Let's understand one important thing that the maxillary sinus is basically an air-filled cavity designed to reduce the amount of weightage of the skull. Also, very importantly, when we look at the maxillary sinus areas, is that it also controls the air that goes in, it moistens the air. So that's why we have what we call as a ciliated epithelium there, and we also have something called a mucus that gets secreted in the sinus. So all these are basic anatomical structures and physiological functions of the maxillary sinus. Now, when we look at operating or doing anything in the sinus area, we need to keep in mind that these are the things that have to be dealt with, and very importantly, we should not do any procedure that would hinder the normal functions of the maxilla. Our goal would be to regain the amount of bone that we need, but nothing more than that. Let's allow the sinus to function the way it should ideally function. Let's look at this simple animation on what we're looking at in the posterior maxilla. When we look at the posterior maxilla, the most important thing are the challenges. The most common challenge is the quality of the bone in the posterior maxilla, which is usually very poor. We normally see what we call as a D3 or a D4 bone in the posterior maxilla. It's not just the quality of the bone, but also the quantum of the bone available in the posterior maxilla that makes this area very, very challenging. When we look at the image on the right side, we look at this. If you have someone who comes to you with the entire tooth in place where you do the extraction, then go ahead and place an implant, you would normally have what we call as a high, well-rounded ridge. So you implant the crown, everything goes in a very nice position. On the other hand, if there's a patient who comes into your office who has got an extraction done some time back, so as the duration of the edentulosum increases after the loss of the tooth, we see that there is a significant change in the reduction of the volume of the maxilla, and the maxilla resorbs in all the three planes, buccally, palatally, as well as apicocoronally. And this leads to a situation where we have a considerable amount of quantum loss of bone in the posterior maxilla. And this poses a challenge. But it doesn't end there. So when we look at this situation, so when I'm putting an implant in someone who's got an extraction done, probably 6 months, probably a couple of years or 2 or 3 years down the line, I'm already looking at a situation where the amount of bone available is much lesser. Now, on the other hand, it is not that just the bone is resorbing. What we also see is as the tooth goes away, we also start observing that the maxillary sinus lining starts ballooning into these areas where the roots were there presently. Okay, so once the tooth is out of the socket, the sinus lining starts ballooning into that area and starts eating up the bone. So we are now not looking at losing the bone only from the crestal or from the oral side, but we are also losing it from within. And this loss of bone from both the within as well as from the intraoral side makes the area very, very small where we can get an implant of a considerable size in. So what you can see here is the one what you see on the left side of your right side of your screen would be an ideal implant size with a perfect crown height and everything else. Whereas on the left side what you see is an implant that is much smaller in size. We have a crown that's much longer, and eventually by the time you restore up, you would actually end up giving something more of a cross-bitis relationship rather than a standard class 1 where the maxillary molars overlap the mandibular molars. So these are the various challenges that we encounter in the posterior maxilla. One is the reduction of the bone from the oral side, also the ballooning of the sinuses. Secondly, we also start seeing that here the bone loss is not just happening apicocoronally, but it's also happening anteromedially. So the tooth, as they get lost more anteriorly, so for example, if you have premolar, first, second premolar, the first premolar, or even till the canine, the bone keeps on getting lost and the sinus keeps on increasing in its volume, and that's why the longer the duration of edentulosum, more tougher the situations end up coming when we start looking at restoring or treating of these cases. The figure on the top is of a completely edentulous patient who was probably edentulous for more than 30 years. You can see that the sinus is literally ballooned all the way to the canine area. Whereas in the image that's shown below, you can see the first molars have been lost long time back, the second molars moved into the first molar area, and you can see that the sinus lining is literally dipped all the way into the first molar area, leaving hardly any bone there for you to go ahead and do anything else. Apart from losing the bone in the sinus areas due to the ballooning of the sinus, we also have situations like this, especially in patients who've got aggressive forms of periodontitis, where we lose bone in the apicocoronal area, the marginal bone gets lost. So in a case like this, what you see on the screen right now, you'll see that the sinus lining levels have not changed. The level of the sinus lining is absolutely the same, but what's happened here is the bone has got lost vertically. So you have a vertical bone loss. Now these are cases which would ideally recommend or which would ideally require a vertical augmentation and not a sinus augmentation procedure to get an implant in and restore up these cases. So let's try and understand, there's a small classification given by Ole Ensen. He says the sinus area, the posterior maxilla, can be classified as type A, B, C, and D. A is hyperpneumatization, which would require sinus lift surgery. So you have the crestal bone that's intact, where you just need, the sinus is ballooned, so you just need a sinus graft surgery. Type B is a situation where you have horizontal deficiency, so you would need a sinus lift along with some bone graft. Type C is vertical deficiency, so you would require to build the vertical height and then, if needed, a sinus graft. And type D is a combined deficiency where you have both vertical as well as onlay graft. So you would need a vertical onlay as well as sinus graft, and sometimes even a horizontal augmentation along with that. This is a very wonderful article by a very dear Isoi member and a dear friend, Neil. He says very clearly, what are the number of sites? Why in India we are to start looking at more and more cases requiring sinus augmentation? This article by Neil Bhatwadekar and Ninad Pade states very clearly that 55%, understand that is more than half of the patients that we see with the missing molar or a premolar area have ridge width that's less than 6. Considering the standard diameter of an implant in the posterior maxilla would be not less than 4, we have very minimal amount of bone when it comes to the buccolingual width. Also, let's look at these two, the other numbers, that is 67.83% of molar and 44% of premolar sites at a vertical height less than 8 mm. So if we're considering that the standard implant placement height, the standard height of an implant in the posterior maxilla, molar or a premolar site would be 8, then you're looking at augmenting minimum 60% to 50% of the sites. So this is a very, very considerable number. So it means that at least 50% of the patients whom you're encountering in your day-to-day practice with the missing molar or premolar areas would necessitate some kind of augmentation. It can be an indirect sinus graft or it can be a direct sinus graft. But what it means is you need to be prepared to augment the posterior maxilla in at least 50% of the cases that you would see in your practices. Let's look at one more article. What does it say? It says they are studying the prevalence of sinus augmentation with maxillary posterior implants. It's a retrospective study where they studied around 272 sites which required augmentation out of 502. It means that world over also the data is nearly same. Nearly 50% of the implants that are placed in the posterior maxilla would require some other kind of augmentation, and that's why it's very important to know about the sinus augmentation procedures. Going by the history, pretty old, in 1960, you can understand Boyne published the first case of a sinus lift with the lateral axis, but it became very, very popular only by the work of Hill Tatum in the year 1974, where we demonstrated a maxillary sinus floor augmentation and then implant placement in that area. And then eventually it was Summers who converted or created the crestal approach, and that's why we now have two approaches to augmenting the sinus. One would be a crestal approach and the other one would be a lateral window. So let's look at what are the factors that would govern me into doing into a sinus graft. First and foremost would be extension of the sinus. So that's how big is the sinus. Secondly, expanse of the edentulous area. So it would be whether I'm dealing with the first premolar all the way to the second molar, or whether I'm dealing only with the first molar area. Secondly, I'm also looking at sinus grafting. This is my individual classification. Please understand that if I have to augment the sinus for a completely edentulous foundation where I'm trying to restore a full arch maxilla, then my approach would be a bit more different than when I'm doing it for a partially edentulous foundation. So that's how I would look at the way I would look at doing a sinus graft procedure. Let's look at the first and foremost let's look at this sinus pneumatization. The sinus pneumatization, I just tuned out to just check whether I'm online. Himanshu sir, can I just get a feedback? Am I online? Yeah, let's look at okay, let's look at this situation now. What do we mean by sinus pneumatization? Very similar to the same picture what I had put earlier. You can see that sinus keeps on pneumatizing into every missing tooth areas. One of the very important factors that we have to look at when we're looking at how much does the sinus pneumatize is the relationship between the roots of the teeth to the sinus lining. There's a wonderful article done in the OOE which shows us the relationship of the roots to the sinus linings. Now you can see the various ways where the sinus lining is 0, 1 to 4, and as well as in the bottom figure. Okay, why is it important for us to understand the relationship of the root to the sinus lining is it will help us determine whether whether I can extract the tooth and leave it alone to heal naturally, or should I actually extract the tooth and do a socket graft? Because if example, in a situation like number 2 on the top row, if I'm extracting the tooth and allowing it to remain like that, then in all likelihood the sinus is just going to balloon down. Very similar to what I see in figure 2 in the lower border and the lower series of images. So now I will, as a clinician, I will have to make a call whether, if I'm not able to put an implant immediately, then I would do a socket augmentation. So it's very important to know the relationship between the roots to the sinus line. Let's see some radiographs of some of my own cases. Now you see the extreme right image on the extreme left image on the screen. You can see that the sinus lining is literally gone between the two roots. So if I remove this tooth and I'm not putting an implant immediately, then the sinus lining, the dip what is there in the center, is just going to blow down all the way, and I'm hardly going to have any bone to put an implant 3 or 4 months down the line. Similarly, the middle image, and you can also see in the image on the extreme right side, where you see the palatal bone is hardly has any bone due to periodontal disease, whereas on the buccal we have some bone available. So now you have to make a call on whether you want to remove the tooth and do a socket augmentation. So it's very important to know the relationship between the sinus lining and then the roots of the teeth. Let's look at a situation like this, the same image earlier. You can see this premolar on the left side and as well as on the right side. You can see that the bundle bone is just right around the apex of the teeth, and the rest of the tooth hardly has any bone now. Now, if I remove both these premolars for whatever reasons, and if I leave them alone, then when I re-enter to place an implant, I'm not going to have adequate amount of bone. So it's very important for us to understand that these are those critical areas where after extraction of these kind of teeth, I will, or we rather would rather do a socket augmentation. I would put a material into the socket so that would hold the volume of the socket, and then you can just go ahead and put an implant in a more simpler manner. Okay, so that's why please understand it's very important to know which roots or which sockets can be augmented, rather should be augmented, and which should not be augmented. Again, similar situations here. Now, whereas the image on the extreme left side of the screen of the premolar, of the single-rooted premolar, you can see that you can remove the tooth here. You have a considerable amount of height and width of the bone. So this is a case where I can extract and just leave it alone, and I'll still have a good amount of bone available. Whereas the one on the right side, I'm not sure whether I'm going to get bone when I remove the teeth and allow it to heal and get an implant in at a later date. Let's look at this. Also very important to understand is we have to see how good are the buccal and the palatal walls. Okay. Now you can see that we always concentrate on the crestal height of the bone, trying to see how much is the residual bone height, and that would help us determine whether we can put an implant simultaneously along with an ISL, or it would need an indirect lift. One of the very important factors is try and see how good are the buccal and the lingual walls. The buccal wall thickness will help us understand how much time would I need to make a window and what instruments I would use to make a window. Whereas the palatal wall thickness is also going to tell me whether I will have, when I reflect the flap and go it all the way down the line, to expose the medial wall of the nose, a lateral wall of the nose rather, in that area, whether I'm going to get good amount of osteogenic cells there. We have to understand any graft material that's put in the sinus has to convert into bone eventually. So I'm looking at area which is thicker and which is something that's going to give me more amount of cells. Also, we have to look at situations something like this where you are having an iatrogenic issue of what we call as oroantral communications. Now, if you look at this series of these three images, they're all of the same patient, where extractions have been done quite a few years back. Soft tissue was closed, however, but the bone never filled into those areas, and now you have huge oroantral communications communicating with the buccal aspect as well as through the from one socket into the other area. So now these are situations where you start have to scratching your head and try and see, oh God, from where am I going to get the bone, where am I going to get the cells, and where will I have to graft to get some implants into this situation. So certain parameters are very important for us to understand when we look at augmenting the sinuses. Yeah, exactly. Huge oroantral communication here in this picture that you can see that. One more issue was some of these old patients who had those implants done long time back and then they've lost those implants for whatever reason. You can see in the 1/6-1/7 area, those implants had severe amount of peri-implantitis. They lost the bone. By the time the implants were taken out, you can see a huge amount of oro-internal communication. There's hardly any bone available there enough. So these are those sites which would look at you starting to think, okay, how am I going to get bone in these areas? Okay, yeah, so this is how that case was eventually solved. We did the sinus graft much higher up and then closed down the area and then eventually restored up this case. So I always pray that none of us should encounter these kind of cases. Okay, the next important thing when we start looking at direct sinus graft is what we call as the septa. We have to understand that the sinus is not just one empty whole cavity, but it's got some bony projections into it. Now, there are various studies which have shown us various kinds of septa that are available. Some are complete, some are incomplete. So just have a look at the wonderful classification that's come by Bornstein et al. Okay, what they say very simple terms. 66.5% of maxillary sinuses in males have septa, around 56 in females. 61 are coronal and 77.6 are axial and sagittal. So you have bone projections going into the sinus in various planes, vertical as well as horizontal. Okay, yeah, this is just a schematic representation of the various septa that has been classified. Vertical septae, horizontal septae. Some are complete, means which run from one wall to the other and seal it off, and there are some which stop in between. Okay, so we will encounter septae. Sometimes the septa are very, very favorable and sometimes they are unfavorable. Okay. One more study showed around 56% of the incidence of septae. So we are looking at 56%, around 50% of the maxillary sinus that we encounter should have one or the other type of septa. 63% of them are coronal, that run vertical. So let's look at this case, a series of radiographs again. You can see that there is a septa which is horizontal, which is running from the buccal to the palatal on the first set of images on the right side of the screen, and then you have on the left side of the screen 3 images where you see a septa that's going all the way up, vertical septa. Okay, this is what you see here is septa which is incomplete. Sometimes if the septa have got a decent degree of thicknesses, we can actually just use the septa, because you have to understand septa is nothing but 2 hard cortical plates and probably some amount of cancellous bone in between, and you can actually go ahead and put an implant in this area. You can just avoid all kinds of sinus augmentation. So this is just how that case was done, with no augmentation done. The implant just went into septa and it's probably the best kind of bone available in the sinus for you. So understand, reading your CBCTs and trying to see where the bone is goes a very long way in deciding where you to get your implant in. One of the other factors in the maxillary sinus that you have to consider is the vasculature. We have to understand that the maxillary sinus is highly vascular. It contains a very high amount of blood supply. Okay. Apart from the capillarity, one of the important things in the maxillary sinus is presence of a vessel. Now, this vessel is a part of the posterior superior maxillary artery. Okay, and it can be present in 3 areas. It can be present within the mucosa, it can be present within the sinus, it can be present within the bone. Okay, I have personally encountered them only when I read the radiograph on the bone. I have not had a case where I saw an actual vessel. There was a case which was posted by a very dear friend Tarun sometime back on a forum, where I saw he showed a very clear cut vessel within the substance of the sinus. I personally haven't seen. Okay, so let's have a look at it. And how do you detect the vessel? In your cone beam images, in your CBCT images, what you have to do is you have to come to the extreme periphery and align your section lines along the bone. And when you align those section lines on the bone, then you start seeing a clear line in the bottom right corner. You can see those, a clear line of bit in the bone, and this channel, what you see is where you have a vessel within the maxillary sinus bone. Okay, yeah, you can see here in this image the white line section. That's where you actually start seeing what we call as the vessel. And the same vessel you can see here on the extreme right image. You can see there's a small dark tinge here. Okay, and that's a point is a vessel. So now Why is it important to know the vessels and read it? Very importantly is that when you have to decide making your sinus windows, when you have to make your cuts, you have to make the cuts in such a manner that the vessel is either included or completely excluded. If you're trying to section it right there, then you're anticipating considerable amount of bleeding, because there's no way you can ligate a vessel within the bone. Okay, and you're just waiting and praying for the bleeding to stop. So understand and mark the vessel within the bone in every sinus case that you want to do, especially with a lateral approach. A crestal approach would be fine. It's only when you're trying to do a lateral approach you have to be considerable. Okay, yeah, this is how it would appear on a cross-sectional image. Okay, yeah, this is the same case where we had done a lateral window approach to augment, and then you can see where the window cuts are. The cut is right just below the vessel. Apart from that, we have to understand that the vessels in the maxilla and in the mandible keep on anastomosing completely. So this PSA artery can actually continue and then communicate with the infraorbital vessel. So that's what. So you can actually draw a wonderful line if you start reading the CTs completely, and then you can actually see this here on the 3D reconstructed image here, that the vessel which is running on the lateral wall of the maxilla is coming down along the vertical in relation to maxillary canine area. It's communicating with the infraorbital vessel right here. So it runs like this, communicates here, and then comes down. Yeah, that's what you can see. It's running there. Okay, so that's about the basic considerations that we have to look into. That's the amount of pneumatization, relationship to the roots. We're looking at the expanse of the sinus. And then now eventually, let's come to the crux. That's what do we mean by sinus graft, when we do it, and what are the various ways to do it. Okay, yeah. By definition, when the amount of bone apical, or rather the amount of remaining height of bone in the maxilla, posterior maxilla is less than 6 or 8 millimeters, where you can't put a well-sized implant for that particular indication, then you'll have to augment. So that's what I would look at it. You have to elevate the sinus flow either by a direct or an indirect approach. The direct approach, in my opinion, and where I would do a direct approach in every case, would be when I have a remaining bone height which is less than 2 millimeters. Okay, if I have a RBH of less than 2 millimeters, then I do a two-stage. That is, I would do a sinus graft first, come back later, and then put an implant. If I have 4 millimeters or more, then I would do a sinus graft and put an implant simultaneously. It would still be a direct approach. So a lateral window where I would lift, put the graft, but place the implant simultaneously. If I have 4 millimeters or more amount of bone, if I have anything lesser than 4, then I would do a two-stage approach. Some people would say 3 mm. One of the factors that you have to understand is not just the height but also the width of the bone available. For example, you may have a 4 millimeters of height, but if the buccolingual width of the bone is very, very less, for example, if you have buccolingual bone width which is just 4 millimeters, then it would not be a very ideal situation for you to put an implant simultaneously. Okay, in that case you would rather do a two-stage approach. So you have to always understand when we use the word RBH, it is not just the vertical, it also the buccolingual thickness of the bone that has to be considered. Okay. On the other hand, if you have 8 mm of bone, more amount of bone available, then you do an indirect. You don't even need to put in a graft in that situation. If you have anything lesser than 6 millimeters or lesser, then you do an indirect and then you compulsorily put in a graft. Okay, there are two ways of looking at it. There are some people who say you don't need to put a graft, but you can always say I would rather put a graft and keep it safe. What are the outcomes? The results are very, very encouraging. We have to understand that sinus grafting is one of the most successful of all implant surgical procedures. So coming to direct sinus grafts, what are the different approaches? What we have the following approaches. The good old way to do a direct sinus lift and make a window would be use of a fluted bore. You can use diamonds now. You can use various other kits like a glass kit or a DASK, and you have plethora of these different names floating around. The basic idea is that you have to make a window on the lateral aspect of the maxilla and then either remove the bone or lift the lining. Eventually, the idea is you lift the lining, put your graft, and then put the implant. Piezo surgery and hand instruments are very, very important. You have to understand whatever instrument you use to make the lateral window, the most important thing is to have a set of hand instruments, because at the end of the day, making the window is only one part of the entire sinus graft direct approach procedure. So when you make the window, you can use a burr, diamond, anything else, but what's important is lifting or the elevation of the sinus lining has to happen with the hand instruments, and that's the most crucial and the sensitive part of direct sinus graft procedure. Okay, let's look at a small classification. Eventually, this is a wonderful study. What they said is, due to the kind of variations that are there, it's not actually possible to classify sinus. So there's just one picture which I'll put through now. Yeah, that's coming on the screen, which classifies the sinus on the distance between the lateral wall and the medial wall of the sinus. The only thing this would tell you is the quantum of the graft that you have to put. Okay, that's why every time you have a patient for a sinus augmentation procedure, you do the CBCT, and once you do a CBCT, you have to evaluate what is this volume, because this volume would determine the amount of graft that you have to put and the amount of money obviously that's going to cost you to put this. Okay, so understand, measure this volume of the sinus. Just a small brief outline what graft I would put. We all know about the various bone grafts available now in the market and with the patient. It's just a small overview. Yes, that's how we would classify all our bone graft materials. I'll just escape, and because I've just hide this one line. Yes? Yes. Okay. So let's classify the different bone graft materials that we're coming across. Okay, eventually the best source would be automatically the autogenous live bone, what we would consider from the patient's own sources. However, there are allogenic bones available. There's animal derived and the synthetic hydroxylapatites, and then bioactive glasses and everything else. At the end of the day, what's important is, let's understand this. Any graft material that we are looking at, I'll just check whether I'm online. Yeah, okay. Let's just check this. Yeah, any graft material that you choose to use in the sinus graft, eventually we have to understand should eventually form bone, whether it forms bone on its own, whether it uses the native bone to form new bone, or whether a material just acts as scaffold and then the nature takes its own course and forms bone is important. What's important is for us to understand what happens to these graft materials when you place into the sinus. When you're placing materials into the sinus, this is what we're looking at. Okay, the graft, once we place into the sinus, forms a clot, it merges with the clot, then the cells from the adjacent area invade the bone and then eventually form the bone. This is how an autogenous material works. When we use any material that is not autogenous, something that doesn't have the ability to form bone on its own, then what's important is the material that we use, which is factory made or anything that comes in a bottle rather, whether it's animal or any other derivative, any material that comes in a bottle, the job of that material is to stay there. Stay there till the host forms a bone on its own, and the job of this material is that it should go away. It should go away, and then when you see this same patient back, probably after a few years, the trabeculation, what you have in the bone, should just look exactly the way a natural bone would be, and that would be the best graft material. So if when you ask me a question whether if you're looking at what would be the best material to use in the sinus, there are various combinations of grafts. So let's understand that any material that you use apart from autogenous would be the one that would convert into native bone at the fastest, or resorb and replace with the host bone at the fastest. That would be the best graft material. So how do we choose which graft material to use for any standard defects? Would be the osteogenic potential of the site, the recipient bed and site of the defects. Okay, this is important. I'll just put this, yeah. The maxillary sinus, fortunately, is a very high osteogenic potential site. Means by the very anatomy and the design of the maxillary sinus is such that it has the ability to form bone. So you actually did not actually put autogenous bone in that area, but however we can debate this part a bit more later. But by definition, the maxillary sinus has the ability to form bone on its own. So you can use a graft material which has less osteogenic potential. So you can use any material that is not live. Can be a conductive material or an inductive material. But let's see why we use autogenous bone in most of this in sinuses. Okay. Yeah, it's also important that nowadays, as a standard operating protocol to enhance the rate at which the graft material has to integrate, we would look at combining all the graft materials with a platelet-rich fibrin or platelet-rich plasma so that the graft integrates and forms a good quality of bone. Very importantly, is a good quality of bone at the earliest. Yes, this is a wonderful statement everyone has to remember. Sinus mucosa contains mesenchymal progenitor cells. Okay, and when the minute we use the word progenitor cells, it means that these cells can be tuned. These cells can be tuned and then eventually be committed to form osteogenic cell lines or a fibroblast or whatever. So the kind of tuning you do or the signals that you give to these mesenchymal progenitor cells, they would form that kind of a tissue. And that's why when we use lift a sinus, we can form good bone, sometimes even in absence of a bone graft material. And that's why we are looking at situations where nowadays there are people who are just lifting the sinus lining, stimulating the rest of the native bone to form bone on its own without use of any material. So by that definition, sinus lining is a very, very high osteogenic potential site. So any graft material used in the sinus should still work and should give you wonderful results. That's where the question comes, whether you have to graft or not. Please understand, when we use these words meta-analysis or systematic reviews what are published, a lot of them are actually not worth their weight in the salt. I'm just quoting one because most of these authors who are listed there would not have even one study of their own RCT which is done to actually say that yes, this meta-analysis is a good one. But this just to say that what it says here, I'm just reading the conclusion there, that is the current available evidence based on aggregate and individual patient data, says that maxillary sinus elevation without grafting and simultaneous implant placement is safe and effective technique with high survival rates, especially for implants with more than 13 mm in length. So it means that anything that is smaller than 13 mm should not hold up well. So please do not just go by what the publications say. I would still say that I would recommend use of a material into the sinus to form bone. Okay, one more study, again maxillary sinus lifts with or without graft materials. You can see here there's a graph on the right side which says the red is without graft materials and the blue is with graft materials. Okay. They say that the success rates are still the same, and comparatively the amount of bone height what gained with a graft material or without a graft material is nearly comparative. Okay. So, similarly, again, one more study. So let's look at now coming to the clinical aspect of it. Let's look at this. The most important procedure point we have to consider whenever we are doing any procedure clinically is the local anatomy. Okay, when I have to do a sinus graft procedure, I would look at 2 points in concern. One would be obviously the artery that I'm looking at on a CBCT. Second is the RBH. The lower border of the cut that I make, you would see in the schematic image, would mean that where it should start. So let's look at this. Yeah, the hand instruments. Yeah, let's just. Yes. Yeah, this is a schematic image that shows us what's the residual bone height. Now consider it's 3 or 6 millimeters. When I am doing a lateral window sinus approach, so I have a lower cut and an upper cut. The lower cut, or the cut which is towards the crest, has to be probably at a point which is a millimeter or two coronal to the rest of the bone. If this cut is too apical, then you would still be in bone and you would not be able to lift the sinus lining. If it's too high, then you would end up lifting too much of a lining and then end up putting a lot more material. So a single stage protocol would be where you have considerable amount of height available to get a good primary stability on this implant. So what you do is you lift the lining, you prepare the osteotomy site, and then put the first layer of the graft, and then put the implant, then put the second layer of the graft, and then you can always close the lateral wall. So that would be your one-stage protocol for a lateral window. So you lift the lining and put the implant at the same time, provided the amount of bone available is adequate enough to give good primary stability to an implant. Then you come back and restore it. The advantage of this is that your entire procedure is done just the way you do a conventional implant. Probably at the end of 4 months, you can finish off the restoration of this case. On the other hand, there are situations where the RBH is less, it's a millimeter or probably 2, and would not allow you to place an implant simultaneously with good amount of insertion torque, and you're not sure of getting an implant in the right position, or rather with a good insertion torque and you're in doubt whether the implant can slip into the sinus. In those situations, I would recommend that you just do a two-stage protocol. So what we do now is you lift the lining, you put the graft material and close it off and just leave it in situ for the next 4 to 6 months or probably 8 months or 12 months depending upon what graft material you use. That's where the quality of the graft that you use values. Okay, so you put the graft, you close it and just forget it there for the next 6 to 8 months. Then come back, do a conventional osteotomy, put your implant in, and then again come back at the end of 3.5, 4 months and then go ahead and do a restoration. The issue with a two-stage protocol is that it extends the duration of your intervention. So a single-stage protocol patient would be done and dusted by 4 months, whereas here it would probably take 8 or 10 months depending upon the kind of graft material that you're using. Just look at a small clinical video of a direct sinus graft procedure. This is on the right side. Okay, some of these cases are pretty old. So nowadays some of these would still go into an indirect sinus graft, but some would still do an indirect. Now you can look at this case. Yeah, that's the intraoral image. You do a full thickness flap, and when you see a rough kind of a surface on the crest, it means that the bone in that area is very poor. Now you look at this case, I'm right now using a piezo, but initially I had used a burr. Okay, why studying the CBCT is important is to know how thick is the bone on the lateral aspect. Thicker the bone on the lateral aspect means that you're cutting a large amount of bone. So you can initially use a fluted drill and then probably use a piezo, or you can nowadays you can use the other systems available. But yes, if you have very thick lateral bone among the lateral side of the sinus, then you're going to take considerable time to open it. And usually a lot of errors happen during this procedure. Means this bone doesn't go away very fast, and that's when you tend to lose your patience. The key is patience when you're making your lateral windows. Okay, it's going to take some amount of time. So if you have a thick wall, then use a burr, thin it down, and then you can start using a piece or anything else. Okay, so just look at this. Now we're starting to come near the lining. As you start thinning down the bone, as you come near the lining, you can start seeing something called as a grayness. The membrane starts appearing gray. Okay, then you keep on checking where it's getting held up. Slowly, yeah, slowly detach at the lower border. I still have some bone. It's always important that you don't leave a sharp edge at the margins of your osteotomy, because that's where the first tear will happen. So that's why you take your instruments. This especially happens with the piezo. You use this what I call a foot, the elephant foot kind of an instrument, and then start using the hydrostatic pressure to push the sinus membrane in. Okay, along with the bone. For beginners, I would not look at you to ripping out that thin piece of bone, but yes, if you have considerable amount of experience, you can then sometimes, nowadays I actually end up taking out that piece of bone that's there, and then once the procedure is done, I tend to place it back. Yeah, but otherwise, yes, if you think it's not easy to take it out, just leave it there. It would form the new roof of the sinus. I would just, yeah. So you then use the hand instruments, go on the floor, then the mesial, then the distal. Just muting the video. This sinus is pretty vascular. Okay, just forward it a little bit. Okay, slowly, very, it's a procedure where you need a lot of patience, so slowly lift it up. Yeah. So by the time we're completely lifted, now you can see that the small bone window has gone top. It forms a new roof of the sinus. And then, yeah, that's what you have. You can see how thick is the lateral wall of the sinus. Okay. Then you can take the material of choice. This is a combination of bioactive glass, that's no-bond marshals, along with some amount of autogenous what I just scraped up. In the beginning part of my sinus work, I used to always compulsively put a membrane, considering that there is always a small amount of tear. But nowadays, I just put sometimes a cola tape or a Novo tape and then seal it off. You can even use a PRF there. Once you fill the entire sinus with the graft, what's very important is to close the lateral wall with the membrane. If you've taken that piece of bone, you can use that. Otherwise, it's very important to close the lateral wall with bone or a membrane. Sinus failures have happened due to impregnation of the soft tissue from the mucosa into the sinus rather than anything happening to the graft. So it's very important that you close the lateral window of the osteotomy with membrane. Yeah, the same case. By the time the patient came back, then we finished up restoring up case. This is done in probably 2012. Yeah, that's the radiograph showing you the sinus graft. Yeah, that's the amount of lift that's gone there. That's re-entry time. That's the implant. Yeah, this is 2012, and now you can see here in the year 2020, I just saw this patient last month, and you can see that the bone what is grafted into the sinus area looks very much similar in its trabecular pattern as compared to the natural bone. So that's what you want. The bone that we use into the sinus should start showing signs of trabeculation. It means that that bone is alive and kicking, and it can maintain osteotomy. It can maintain the osseointegration around your implants at all points in time. Yeah. So this patient actually came back for a loosened prosthesis, so we just took it out and then just fitted the prosthesis back to the patient and then sent him. This is my first case, my first sinus graft. I did it in the year 2004. Looking at this case, I would probably nowadays I would say I would not have done a direct sinus graft in no way. Okay, but just look at this historical perspective from my personal opinion. So lateral window, you can see this is done with a drill. Okay, you can start seeing what we call as the grayness of the membrane, and you can see the small red lines on the grayness. It tells how vascular is the sinus lining, and that's what makes the sinus very osteogenic. The more the blood supply, better the sinus for is. There's a case, obviously we used Autogenous for this case. You can use any material, but that was a time in 2004. There was a time in India where we hardly had any graft materials available for whatever reason, so we had to rely on Autogenous, so that's what happened. So the case now, simultaneous implant placement along with sinus graft. Okay, so you lift the sinus, you tent the lining, put the first layer of graft, then your implant, then the second layer of the graft. Okay, and then once all the autogenous is done, then you can layer it with slow resorbing mineral, and that's how it looks. Now, when I see this picture, I keep on saying how much. I literally have put a 25 mm implant at it, that would still be in native bone. That's the amount of height that we had got. That's how we had restored it then. That was the native sinus lining on the left, and what you see on the left side of the screen is the amount of bone. Can see this over a period of time, the bone has undergone change. There's been a nice trabeculation happening, and this is the picture on the fitting, and this is how it looks right now. It's around 12 years down the line. This is 2016 when I saw this patient back. It looks exactly wonderful. Absolutely no bone loss or even at the crest. Let's look at this case again. Today it would qualify for a crestal window. Again, this is probably done 2005, 2006. I wanted to show this case to show how things, what we used to do earlier and how things have changed now. Okay, let's look at this case. Yes, single missing tooth. It's a premolar and a sinus graft to be done for that missing premolar. A huge lateral window, and you can see that the lower border of the cut, the lower border of the sinus window has happened so higher. It's literally at the distance of around 12 millimeters from the crest, and you can see as I proceed with the case. Yeah. So we used some amount of autogenous, then there was probably some Rocky Mountain available then. So we use a mixture of that. Now you can see here, I actually just lifted and rather pushed the lining away. The lift was so much that I would probably end up putting 10 cc of graft and that would still be insufficient. So I had to limit the amount of lift that I did. So what we did was we lifted, we put the implant, and then at the apex of the implant, I limited the graft and then sealed the implant or rather the sinus cavity with the membrane. So I had one membrane sitting on top and then one more membrane closing the side. Eventually then finished up restoring this case. Yeah, that's how she looks. Yeah. So yeah, what's important to show here is if you look at the implant, the osteotomy was literally near where the apex of the implant would be. So that's how high was the lower cut, and that's what you should not be doing. Nowadays, we make the lower cut much lower, much apical. And what's important is to understand that whatever amount of lift that you do nowadays, we're seeing that the bone gain, what we achieve in the sinus area, would settle at the apex of the implant. So that's what you would see in this case. Now this is probably around 10 years down the line when she came back for a follow-up, and that's what happened. You can see here when we redid the CBCT, the gain of the height is around 10, the total height is around 12 millimeters, and the tip of the implant is now probably thin bone, but the bone is not going to move any more down from that point of area. The bone settles down at the apex of the implant. Let's look at one more case. It's a bilateral missing teeth. Both the molars were missing. She had a 3-unit bridge, and then she was unhappy due to food getting stuck and blah blah blah. So we are now looking at restoring up this case. That's the amount of bone available. What I was looking at is the RBH is hardly a millimeter, and these are the cases which require a direct sinus lift. Okay, and you can also see the buccolingual distance. The distance between the mesial side and the lingual side is so high that it would require a considerable amount of graft to augment this area. Now you see, as your experience and as your this one changes, and obviously due to the inventory, we start now making very smaller windows. The windows becoming more conservative, much smaller. So on this side of this patient, I actually ripped out the bone, and on that side I kept the bone intact. Both the sides were grafted, and you can see the amount of bone gain, rather the grafting done. Okay, this was on the day we had grafted, and this is on the day we were planning the implant placement. So a 16 mm bone height eventually helped us get probably a 13 mm long implant. So this is the image after the implants have been placed. You can see the bone volume, which was pretty high, has now slowly come down and is now settling down at the apex of the implant. And then eventually this case got restored. My mandate was only to do the implants and not the natural teeth. Yeah, that's how the post-op OPG looks. You can see that the amount of bone was nice, neat, starts looking more and more trabecular, and that's what we want. So you would recommend to use a graft material that would convert into bone and resorb off. Okay, and that's why one of the reasons why I would recommend use of bioactive glass is that probably 2 or 3 years down the line you should start seeing good travaculations of the bone. Let's look at one more situation. I was telling you about the thickness of the lateral wall. The cases what we saw earlier had a thick lateral wall. Now look at this case, so thin. The lateral wall of the maxilla is so thin that, let's just play this video, you can see that. There's no way I could actually make a window. The burr would just rip out everything that would be there. Okay, so what I'm just doing is I'm actually just scraping out the thin piece of bone there. Just a second. Yeah, you can see here, and it's so thin that the piezo tip would probably just go in and dip into that area. Yeah, you can see that. That's how thin is the bone. Just a second. Yeah, you can see that there's hardly any thickness to the bone. Yeah, you can see there. Yeah, there's hardly any thickness to the bone. Okay, and even the lining per se was very thin and very fragile. So yeah, the window was pretty small, so I couldn't use this. So we went back to the tip. so that you can make the lining a bit more bigger, the window a bit more larger. The simple approach, simple guideline to make how big should the window be, it should permit you to place your instruments comfortably, should give you good access to the area, and more importantly, it should give you the instrument which should carry your graft. It can be a syringe or a graft carrying syringe, whatever you do, it should fit snugly at the mouth so that then you can inject the graft material. That should be the size of the window. Don't make them too small because you will risk a tear. Don't make them too big because you'll have to end up putting a lot amount of graft material. Yeah. Yeah, now the time to, so I'm now just still making the window a bit more, this one, detaching the lining. Yeah, you can see the bone is so thin, there's no way you could use any instrument. Piezo probably was the best one to use in this area. Yeah. Yeah, you can see that. Actually, you can see the instrument through the lateral wall. That's how thin is the bone. When you have a thinner bone, it also means that the number of cells that can come into this graft that you're going to place there are going to be much more lesser. Okay, so it's important that you place a graft that probably considers some amount of cell, or you delay your re-entry time, because thinner bone, lesser the number of cells that are going to be there. Secondly, avoid tearing a membrane in these situations, because if you tear a membrane, then in case you're putting a collagen membrane there to cover the tear, then you are actually blocking the cells from repopulating the area. So you have to use a membrane that would resorb off much faster, or use something like a PRF or something to seal off the tear. Okay, don't use a standard bilayered collagen membrane to cover off these tears. Just forward this a little bit. One second. Yeah. Yeah. So now we have made a window that would be just adequate enough. Lifted the lining down, and then let's just look at what to do further. Yeah. So that's how we had a small tear there, which we covered with the membrane. Then there was some amount of autogenous bone that was harvested, cracked, lateral window closed, and that's what we have now. Whenever you're placing your graft material, see that you pack more towards the palate rather than the buccal, okay, because you have more bone and more intact cells coming in from that area in this case. So I wanted to use the cells from the palate side to repopulate the graft, because buccally I hardly had any bone to repopulate. Now that's what happens. Now when we re-entered to open, I just wanted to see what's happening there. You can see that the window, because the bone around on the buccal side was very, very thin, the entire window was still not filled up. So we just put some graft and membrane like a GBR there. And so that's how your implants look now, and the day we place the implants. And eventually we restore up this case. Yeah, that's what it looks like. That's the implant in the completely augmented sinus. Let's look at one more. This is a case. This was done way back in 2012 again. A patient had a denture, implant supported overdenture in the maxilla. This implant on the extreme right had lost. So he now desired a full fixed restoration, and that's what was the remaining bone height in the posterior maxilla, both on the right as well as on the left side. Okay. So standard operating protocols now, making the windows. You can see the lift, and then this is a case where we used a combination of xenograft that was cerebral bone, that was the only bone available then, and then some amount of autogenous scrapings that we could get from certain areas. So that combination was used. Compulsorily close the lateral window, and same thing done on the left side. We had a small tear there, so we put a membrane to close the tear and then close with the graft. Whenever we use a xenogenic material, especially xenogenic hydroxylapatites, we have to understand that these materials will have to be packed much more loosely. The idea is that you use a material that would have a lot of room in between, and when you have a lot of room in between, that's where the blood would go in, form the clot and hold up. If you pack a xenogenic material very densely, then you're not going to allow the blood and the cells to go into that area, and that would increase the duration for you to re-enter, because this graft material, a xenogenic material, would form bone only between the granules or not within the granule. Okay, even probably at the end of 15 years down the line, if you make a biopsy, you would still see the xenogenic material there. So that's why it's very important that when you use a xenogenic or a slow resorbing material, then you pack it, but pack loosely and not very densely. Okay, so this is a case where we took a biopsy from both the sides. A huge 5.7 dia, 12 long implant went in there. I'll just show you this when we took the core. Yeah, that's what I want to say. This is a case because it was a xenogenic material. We re-entered at 12 months. And what I want to see every time I re-enter and then I harvest a core is this. I'll just go back to this picture. When I harvest a core, that's what I want to see here. You can see this with the trifine. Okay, the crestal bone is in the trifine, and what I see here at the apex, the pink part, is the bone that is formed into the sinus, and that's probably now around 8-10 mm of the height what I could get the core. And this pink is what's critical. I need something that's pink. Pink means that bone graft material what I have there is vascular, and that's what going to carry the cells, and that's what is going to integrate with the implants. Okay, your granules are not going to integrate with the implants. Okay, so that's what happened. This is the same case post-op. Eventually, by the time we restored up, and this is a post-op radiograph after restoration. This patient comes back at the end of 7 years, and that's what happens. What I have this implant, which is there on the left side here, that's lost. And what's important for all of you to notice is you can see this when I use a lot of xenogenic material, and if in case it's got compacted, that's what I see. You see the graft looks very white. Every case where you put in a xenogenic material, okay, wherever you use a hydroxylapatite kind of material, it tends to look more dense, more whiter, and not trabecular, and that's not good. If the more white you have, lesser is the bone to implant contact in that area. So that's one thing you need to keep. That's why you need to get a balance between using different kind of graft materials into the sinus or any other GBR procedures for that matter. So let's do a small literature work. Lateral approach for sinus. How big should be the window? The conclusion is very simple. It says the reduction of window dimensions did not affect the safety of the surgical procedure. So what's important is the size of the window that you make should be critical. It should allow you to instrument well. So whether it's big or small is not of any significance. Okay. Second thing is thickness of the sinus membrane. Okay, it just goes by logic. Thicker the membrane you have, lesser the chance of any perforation that you can have in the sinus area. Okay, this study has quoted that the sinus membrane thickness was around 1.32 plus minus 0.8, and that's literally 2 millimeters. I doubt if one could measure a 2 mm thick membrane unless it was probably a connective tissue graft that was there. So it's very important for one to understand to take this one with a bit of a pinch of salt that you can have a sinus membrane that was literally 1.3 millimeters in thick. Let's look at this case again. Yes, when you look at xenogenic material, most of them come in two different graft granule size, a thick, larger granule size and a thinner granule size, a smaller granule size. Larger granule size materials are preferred in the sinus graft because the intergranule space is much higher. If you use a smaller granule size ones in the sinus, then they're going to be much more denser. So if you have to use a xenogenic material, you're better off using a granule which is more larger in size because it's got more intergranular pore rather than anything else. So and you can loosely pack it. So this is a case, maxillary first and second molar area. The windows being done there, and you can see this, the size of the granule, the white ones there, okay, they are the large size granules. When you use a large size granule, you don't actually need to pack them. They'll just hold up very loosely, and that's important. And the bone would form between the granules. You can see here on the radiograph how it appears. The radiograph appears white. Okay, you can see the granules, you can see some blackness, some grayness and some whiteness. And this whiteness, if you see the 3D image on the extreme left side, you can see that granules literally there, and that's something what makes me desist from using these materials of late. Okay, but that's what was done. This implant, the two implants went in 6 months down the line, then eventually restored, and that's how it looks. But you can see that you can see a clear-cut differentiation between the host bone and the augmented bone. The host bone appears more grayish, darkish, whereas the augmented bone appears more and more whitish. In the same case, a bit of a connective tissue graft to get a better emergence, and then yeah, that's what eventually this case got restored up with two cemented crowns. Okay, that's what happens on the sides. Yeah. Let's look at one more situation on the left side. Yes. This is a case where we used a combination of xenogenic material, some autogenous scrapings, and some PRF, etc. The implants went in. Yeah, this is a combination of the material. Yeah. The reason to show this case was this. You can see that again the sinus lining or the bone window is very, very thin. The amount of native bone is thin. You can see the bone looks yellow, especially this is my personal experience again, especially in postmenopausal women. Okay, and people who are much more frail, much more leaner in form, I see that they usually have much thinner amount of bone. The quantity as well as the quality of the bone, what we see in these patients, is much thinner and yellowish. If I start seeing a bone that appears more yellow, it means it's less vascular. It means that I need to give it that much more time, or I need to use agents that would enhance the rate at which my graft would integrate. And that's why it's important to know and understand everything or the anatomy of the area where you're working or in your patients. Okay, yeah. So let's look at this. Yeah, we'll look at this is a case to show that though the sinus height and as well as the buccolingual width of the bone is much more narrower. Okay, that's pre-op, immediate, and then the post-op after implant placement. That's the implants went in, conventional two-stage protocol. Okay, and then the implants, some software, because we didn't have any amount of tissue on the buccal, so we just moved some tissue from the palate, and by the time we restored up this case, yeah. Of late, I have had a couple of few cases where we had cysts, not very uncommon to see, not very common. So let's have a look at this case. Posterior maxilla again, 2-6. Sign, always make it a point to mark where the artery is. It's a standard operating protocol. RBH was probably around 3 millimeters. Didn't want, because of the cyst, I didn't want to try and do an indirect lift. Okay, so that's the site. Make the incision. Made a big lateral window. You could probably have done away with a smaller window, but the reason to do a big window is so that you aspirate the fluid, and in case you have a tear, that would go into the folds of the lining. So that's what happened. So we aspirated the contents. That's what we got. Okay, I'll just play this. Yeah, you can see here there are two linings here. There's one lining that's ballooning there. Okay, yeah. You can see here there are two linings in this case. There is one thin tear or a slit that you can see there, that's the inner lining, and then there is the outer thick material or the inner lining, the outer lining. So here, due to the cystic or the inflammatory process, the cyst lining probably got separated from each other. Okay, so you have the sinus lining here, and then you have the cystic lining on the inside. Okay, but as long as we didn't tear it, we are fine with that. Okay, so I'll just put this video, I'll just play this again. You can see that this looks as if it is torn there. Okay, and as the patient breathes in and out, you can see that. Yeah. Yes. So just to be safe and secure, thin layer membrane. This is a material. What I've used here is a carbonate apatite. So again, it's xenogenic material, but it's a carbonate apatite. It is supposed to resorb much more faster than hydroxyl apatite. And by the very nature, by the handling property of the material, I find it very, very porous. I find it much less denser than the other two xenogenic materials that I've used. Okay, that's one reason why of late I've fallen in love using this particular material. They're not paying me, please understand. But yeah, this material is something that I'm liking to use nowadays. Okay, so the window, what I'd taken out, I've just replaced it back there. Okay, and that's the lift. Now you can see that in the post-operative radiograph, there are small locules there on top. That's okay, that looks fine. But what's important is the entire cystic, whatever this one is there, it's completely gone. I don't see that haziness of the cystic lining anymore. This this is a IOPA done prior to implant placement. This is on the day, this patient came back probably at the end of 6 months, and then we're looking to get the implants in. Okay. Now, what you look at doing in this case, we're doing a conventional osteotomy. I still do not have the densifying burrs, so I'm still using the conventional drills that come with this one. But what was exciting here is when I did a conventional drill all the way up to 12 millimeters, that's what I saw. I could see the bone getting stick to the tip of the drill. It means that the graft material that I've placed there has formed excellent quality bone, and that's lovable. Okay, yeah, that's what the second drill, you can start seeing pink color of bone on the drill, and that's what you want. And when you look at the osteotomy site that's completely getting filled with blood, it means yes, this is a live active site, and that's the best thing that you can give to your patient. Okay, and that's what you want your graft materials to do, and that's when I have the implant in, and now you can see the bone is all the way till this bone covering the tip of the implant, and you can start seeing that the graft material that we used is, though it's xenogenic, it's much less denser, and because much less denser, it looks nearly as gray as, not as good as the native bone, but yes, or probably I'm anticipating that probably over the next 3-4 years, this bone should start looking or start showing more tuberculations than the other xenogenic material. So that's why the choice of graft materials is very, very important when you're looking at implant placements. Let's look at one more situation now. Yeah, there are situations where you have bone in very weird patterns. Sometimes I don't know why I tend to encounter them or whatever. Let's look at this case here. This is a missing 1/6-1/7 area. The 1/6 area looks fine, but 1/7 area, the buccal bone is completely gone inside. Okay, but I told we did give the option of to the patient that we just do one implant, but she was insistent, no, I want both. She wanted to eat well. So now this is a case where now I've made a window much higher up than what I would do. The reason to do the window such high up was that you lift the lining and pack the graft material from top. It's like this. So you lift and push the graft material down rather than making a window and just put the graft material horizontal. Normally what we do, we make a window, you lift, you put the graft like this, and then you seal it off, and the implant would just end there. On the other hand, this is a case where I made the window here much higher up and then lifted the lining going far deeper down, and very importantly was that you dump the graft from the top. It's like you're filling a ditch or a socket rather than a standard conventional sinus graft. So that's what was done here. You can see that the full length of the implant probably ends here at the lower border, probably still more lower than the lower border of the sinus osteotomy. Yeah, that's what you can see here. Yeah, that's this one, and that's why the graft material probably has just moved out into different areas. Yeah, that's how it looks. And then again, that's the 7 implant area there. So didn't have attached tissue, so we're just moving some tissue from one side to the other, and we're now creating a zone of attached tissue around the 7 implant. 6 implant was fine around the 7 implant, and that's when you finish restoring up this case. And that's how it looks on a periapical. This is my take, absolutely personal opinion. When I am doing sinus augmentations for a full mouth rehabilitations or full arch restorations, okay, I would prefer to use a lot of patient's own bone rather than anything material. Okay, material would be a secondary choice, but I would prefer to use patient's own bone as much as possible. So that's how I stage up my surgery also. Let's look at this case. This is a case completely edentulous, posterior maxilla absolutely nothing available, canine to canine bone is good, mandible excellent bone. Okay, that's the planning. We had thought of initially doing an all-on-4, but then we gave up all this idea and then went for conventional. So that's what happened. This is a patient with his dentures in place. Edentulous maxilla and mandible. So when I am doing planning of these cases, I would always do the mandibular surgery first. On the same sitting, I would do the mandible. And with every implant site, I would consider as a source of autogenous bone. So I would collect bone from every implant site in the mandible, keep it aside, then go to the maxilla. Okay, so that's a considerable amount of autogenous bone that was collected. Then we obviously use some amount of, bottle bone graft material, then some PRF, membranes, everything ready. So then the maxillary anterior implants go in, and now we are doing the sinus graft. So all of this is one single surgery. So we're opening up the lateral windows, and then it's nearly 2.5 cc of graft. You can see there's a mix of a graft in the syringe there. Okay, so you have autogenous, and then you also have the granules. So it's a combination of a bone graft material, autogenous as well as synthetic, that's going in there. And my personal choices are prefer to use these local anesthetic syringes rather than the steel syringe, because I'm never sure that whether my assistants or your nursing staff, anyone, would be able to clean those steel syringes completely. So there's always a chance of something lying in there. So it's always better to use a local anesthetic syringe. You chop off the head and then you're ready to use your syringe. So that's what you do. You pack your graft. If you're using an autogenous material, then you always condense the graft. You can pack an autogenous, because the closer the autogenous graft is, higher is the cellular density, faster is the revascularization, and faster is the conversion to bone. So that's what we did. It's on this side we had a tear, so that's what the membrane goes in there. The graft goes in on both the sides. There's some GBR done on the anterior implants in the maxilla closure. And that's the amount of height of bone available now for us. It would obviously shrink down immediate post-op. These are okay. And 6 months down the line, patient comes back, and then we have now the graft that looks nice and neat, looks good enough to receive the implant. You can see the shrinkage of the graft that's happened, but yeah, that's the implants going in. Yeah. Now, this is one of the complications that one can encounter when you have large sinus. So if you have a large buccolingual width of the sinus, okay, and if your sinus windows have been considerably large and your re-entry time has been shorter, then you would encounter that the lateral window has not completely sealed off, and sometimes soft tissue would have gone in. So it's very imperative that you seal these lateral windows with the membrane. If you're not sealing with the membrane, then it's more often that you will see that. But because the graft is far more palatal than where the window is, our implants are in completely solid bone on both the sides. Okay, so the posterior implants went in. This is standard uncovering, second stage, and that's how we restored up this case. The upper was full arch peak restoration with Emax crowns in the anterior and zirconia in the posterior. Lower was standard PFM milled standard PFM restoration. And that's how it looks for the patient, and that's how it looks on the radiograph. Now you can see here on both the sides in the sinus augmented area, the bone looks more denser. It's obviously started to take a trabecular because there's a lot of autogenous bone that's in there. It's at the end of 1 year post-op. The same thing, looks much nicer. So I think we are good stead for this case. Let's look at one more, very similar protocol again, bilateral sinus, the graft in the posterior maxilla. Again, a combination. The lower implants were done and the anti-implants in the anti-maxilla were placed. The bone from the osteotomy sites used to augment this one. It's the same combination again. And that's where you see the implants in the augmented sites. You have both the augmented sites, the implants in the augmented sinuses, conventional restorations, and that's how it looks right now. This has probably just been done a year back, so all looks good. And that's what you see. You see that the graft material that you place should look one with the native bone, and that would happen with the more and more percentage of autogenous bone that you've used. Yeah, that's how this patient looks. Let's look at some complicated situations. I was telling you about oroenteral communication, and this is a patient. He was a physician himself, and this is exactly the image that I saw when I reflected the flap. When I opened up the flap, this is what was visible. You can see that after the reflection of the flap, the socket, the mesobuccal socket of the first molar is not healed. The second molar area is literally open. The sinus, what you can actually see is the sinus lining through the entire defect. Okay, and this is the occlusal view. So when you see the occlusal view here, there's a mesobuccal socket of this one. There's a palatal socket. Okay, and this is already a torn lining at the mouth of the or at the top of the this one. Okay, so what I probably was struggling to find out how I can restore up this case. So That's when I did a little bit of juggling business. So what I did was I augmented these two sockets. And after augmenting the sockets, what I did was lifted this lining, which is here along with the distal aspect of, I cannot take the cursor there, yeah, along the distal part. The tear was extremely distal to the mesial part of that huge opening. I lifted it and I put some graft material with the hope that it would hold up. So you can see the huge oroidal communication here on the radiograph here. And that's how I just grafted it. So sockets were grafted, those two sockets, the mesobuccal root and the palatal root. And from the distal, I just dumped some graft and some membrane and just forgot it there and told the patient, let's wait. Patient comes back at the end of 1 year, and what I see is some bone there and some bone not there. Okay, so now I had some bone along the buccal wall. On the palatal side of the sinus, you can't see any bone there. It's just black there. Okay, along these lines. Okay, and as I went a bit more distal, again you can see here some bone there and then some bone not there. Okay, so the idea was to get the implants in. So what we did was, in the roots, the mesobuccal and the palatal root of the first molar area, I could get the implants in straightforward. Okay, there was good bone there. On the other hand, in this site where you can see exactly along these section lines there, okay, I had some bone at the crest, and there was a small dip there into the augmented site. Okay, and this is how it looks. So this is the implant site along those lines. And there I actually did an indirect sinus lift. So I made a small puncture, put a novobone putty material, injected a novobone putty, and then inserted the implant at the same time and did a lot of prayers. So by the time we did that, so this is what happened in the distal implant site. So there was a direct sinus lift done on one time. 1 year down the line, this patient stays in the UK. So when he came back, then we did an indirect sinus lift into already direct lifted site and then put the implant in. And then he comes back 1 year down the line. So we had a long time for healing. Then we finished restoring, and this is 2 years recall when he just came, probably 3 months back when he came for his follow-up. Both the implants look nice and neat in function, and these were the implants on the radiograph just on the day we were cementing it. This is this year's radiograph when he came back. So the bone around both the implants look good. Both the implants look nice and neat in function and do not show any sign of any crystal bone loss. So luckily this case held up well. Yes, that's a case of orointral communique which was managed probably a bit more conservatively. There are times when things go wrong, and this happened with this patient of mine. We are looking at maxillary second premolar case with adequate amount of bone where a nice ISL was done and an implant was placed. That's what second stage was done. The abutment was placed to check the fit. This radiograph was done. It looked nice, but when I was torquing the abutment, the implant just moved, and then I just couldn't do anything. So I just removed the implant, allowed the whole thing to heal up. So this was a site of ISL which had failed. There was no graft used at the ISL, it was just a lift. Okay, so this is the amount of bone available now as you see on the radiograph for the implant. That's the clinical view. So now this case, what we did was the buccolingual bone thickness was also considerably less, you can see there. So what we did was we did a sinus direct window as well as a GBR on the buccal. So what was done was we opened a lateral window, augmented the sinus, and then a buccal GBR. And that's what you would see now. The implant, the sinus augmentation, as well as the GBR done on the buccal aspect, along with simultaneous implant placement, and then eventually 4 months down the line, we restored up this case. So that's how it was after the implant and the GBR, and this is how it looks after restoration. So let's look at what happens to the graft that we place in the sinuses. So that's about most of the cases. Let's look at a bit of literature. What happens to the graft? What we place in the sinuses? Is there a volume change? Yes, there is a considerable amount of volume change. This comes from a very respected Dr. Vivek Shanbag and his son Siddharth, a very student of ours. And what they found was in their review is most of the grafts, whether it's autogenous or anything that comes in a bottle, every graft undergoes a certain amount of reduction in size, and that reduction in the size can vary anywhere range of 18 to 45% depending upon what graft and what combination of graft materials you've used. But what's important for us to understand is if you have grafted more, the reduction is more. So what's recommended now is you graft just enough so that your graft would cover the tip of the implant and nothing more than that. So the more you graft is of no use if because nowadays we do not put an implant that's probably more than 12 millimeters in height. So if you have probably grafted 14 mm as your eventual bone height, I think that should be good enough, because if you graft more, that bone on the top is of no use. It's not going to support any implant. Very similar to my first sinus graft case, what I showed you earlier. The next thing, what complications can happen primarily is the sinus membrane or a Schneiderian membrane perforation. And what is the data? 1 in 4. 1 in 4 of every sinus case undergoes a membrane perforation. So please understand, please be prepared to handle this. So every time you do a sinus graft, you should be expecting membrane perforation more in the beginning stage of your life than in the later. Okay, so always be ready with materials by which you can close off the tear. If you cannot close the tear, then what do we do? Let's see that a bit more later. If you cannot close the tear, then you probably refer it to someone. Secondly, you can leave the site untouched for the next 3 or 4 months, and then you can come back and re-enter. And every time you re-enter, you will encounter that the membrane is much more thicker than what you saw in the first time. So usually the second time when you go and lift it, it doesn't tear, but the only issue is that the sinus lining and the undersurface of the connective tissue of the buccal mucosa would have sometimes fused. So by the time you reflect the flap, you'll end up with a tear on that side. Okay. Regenerative potential of the sinus. So what happens with different materials? Every study is going to have some of the other materials better than the other, but in my opinion, autogenous is probably still the best. I would nowadays go towards probably at least 50% for autogenous, then a bioactive glass or carbonate apatite of late. It's been my material of choice nowadays, but yes, you can use any material as long as you understand the anatomy of the sinus and determine your re-entry time. The lower or more denser the graft material, longer will be your re-entry time. So if you use a material that is more osteogenic, you can re-enter faster. If you use a material that is less osteogenic, you'll have to re-enter a bit later. Okay. A few more, couple of things. Yeah, just whether the sinus membrane lining just sufficient. So you have to understand if you follow, some of you follow Dong Seok Son, an excellent surgeon from Korea. Okay, he just lifts the sinus lining, tents the whole lining with the implants, and then doesn't put anything, or he puts a lot of PRF and just forgets it. He doesn't put any material at all. Then he says that is good enough. Yes. It's probably possible in his hands. Whether it's possible in everyone's hand, I don't know. You should try. So you have to understand, studies show, even Ziv Mazer would say that you can just lift the sinus with using PRF alone. There's no need to put any graft materials at all. Okay, but whether it would work in everyone's hand is a question that one should ask. From a personal perspective, I would prefer to use a material. It gives me a lot more comfort, and I know that when I go back and re-enter the site, I will still have bone which I can go ahead and work up there. Let's look at complications. Complications, I would look at dividing them into two things. One is the error. Second is whether we can have an infection, whether you can have a graft failure, and then whether we do a redo. Okay, errors. The most common error that can happen in a sinus graft procedure is improper estimation of the bone height. Okay, very, very important. So understand that without a CBCT, we would not do anything, but sometimes even CBCTs would give you a certain amount of error. So it's important that you evaluate. So I personally would not or ever go by the readings as that come from CBCT center. I always make my own readings. Then you can always see that you have your DICOM files. You can rotate the image in different directions and then exactly figure out what would be the best possible height of bone available, and then plan your procedure accordingly. Because it's not just the height of the bone that's important in planning, as I told you, it's also the buccal angle width of bone. Okay, sometimes you may have 5 mm of height but very less width, we may not be in the right position to get the best diameter implant in. So you have to decide that. Second, always drill the posterior maxilla much more slower than what you do nowadays. You also have densification drills available which you can use. I personally have never used one. I would look forward to using one, but as of yet I am using conventional drills. But my RPM in an augmented sinus, when I have to go ahead and put an implant at a later date, would never cross 300 RPM. It's never more than that. So, secondly, chance of errors can happen from inexperience rather. Okay, so very important that you all get trained, learn to do the procedures properly, and then go ahead and do it. Second thing, over experience, or I would say overconfidence, is also one of the reasons. Probably some of the perforations that I have in my clinic once in a while would be due to overconfidence. I think, oh, what's this? Let me go ahead. No, it's not like the sinus is a very, very sensitive procedure. So be very careful when you do it. Okay, site-specific issues can be poor bone. Yes, we are. Please understand, the minute you look at posterior maxilla, anticipate that you're already in a D3 and D4 and plan accordingly rather than anything else. Next, you can have an infection of the graft. So your asepsis protocols have to be very good. Follow them. There's absolutely no leeway to having following asepsis protocols. You have to understand asepsis is 100% or 0. There's nothing in between. Just look at this case, a small video. This shows a couple of errors rather. That's the reason why I have actually placed this video here. Just note this. Yeah. This is a case what I was doing at a live surgical demo somewhere. Okay. So I had multiple things available at my disposal. So we started with the DASC kit. Okay, to just get a purchase in the bone. Please understand, I had a very untrained assistant or assistant with whom I had never worked. So it's the live demo what I was doing. Some of the, you can understand there's no head cap, etc. on this case, but yes, you know how things happen sometimes when you're working. Yeah, for a live demo situation. So that's a window I was making. Now, as you are making the window, now you can start seeing that grayness around that area. It means that that area, the bone is gone, whereas in the rest of the area, there's still bone present. Okay. The reason why I'm showing you this is at the lower border of this window where we're making, I was far too below. I was far crestal when I was making the this sinus window. So what happened? The window would not move at all. Okay, so I'll just take it. Yes. And now what's happened? The bone, though it's completely detached from all the sides, but at the apex there's still some bone available. Okay, and that bone would not go. And without that bone going, I cannot lift. Just push it up a little bit. So I'm just using now the piezo. I'm using the piezo. Okay. Now, when I used the piezo, that's when I realized that at the lower border, exactly at that point, now what you see there, at that point, there is still bone, and my lower cut of the osteotomy has to go much more higher. So what I do now is I actually correct it. Okay. I actually correct it. So I'll just forward this a little bit. Yes. Now you can see here in this picture, I have now a lower border of the osteotomy, and I'm lifting the lining from that point. The initial lower border, what you have, what you see there, the circle part, is actually still full native solid bone. That's where the bone was there. Okay, so this is one thing that can happen when you underestimate the amount of bone available. So read your CBCTs very well. So we already have a perforation there, so I can just lift it now. Because perforation is in the center, I can just shift the whole thing up, put a membrane and cover it down. The worst site to have perforation is the medial, anteromedial and distal. If you have perforation in the middle or somewhere on the top, it just goes into the fold. Okay, you can see that now the perforation is gone on top. I can put a membrane and seal it off. Okay, you can see there now the lower border of the initial cut is actually full solid bone. So this error can happen when you underestimate the amount of bone. So probably if I thought there was 6 mm of bone and I made a cut, then I would probably be here. Okay, there actually was probably, if, or for example, you see that you think there is 4 mm bone and you make a cut which is much higher, but there's actually 6 mm bone. So that's when it happens. So now what I do is I tucking the membrane in to close off the perforation. This is a technique that I follow for all my surgery, is when I have to cover up sinus perforation, is that I take the membrane and I make 2 cuts on the sides. Okay, so what it does is it takes the membrane inside, but the cuts will help me hold it up so that the membrane doesn't get sucked inside by the once I am done with the placement. So then the part can be just folded on to close the window. So just fold it up. So one sec, just tuned out there for a minute. Yeah. So I am now placing the graft. We didn't have a graft placing instrument there, so I'm just packing with this one. This was simultaneous implant placement. Yeah, just once the implant was there, then the remainder amount of the graft that's going in. Yeah, that's the thing. Let's look at the other complication. Yeah, that was a surgical error of the judgment of the remaining bone available. These are other things that can happen if you don't assess the good quality, whether the quality of the bone is good or bad. Then your implant can just slip into the sinus. It can happen immediately, or sometimes it can happen delayed. For example, you place the implant and then for reasons beyond human control, what I say, sometimes the bone just doesn't hold the implant and implants can go to the sinus. So what's important, if an implant gone into the sinus, we have to understand that we have to locate where it is. So we locate whether it is between the membrane and the bone, or whether it has perforated the membrane and gone into the substance of the sinus. Removal can be probably tried with a blind procedure, which I would not recommend. The best would be to do a Caldwell look, open the full window and check and see. It's always better to have an endoscopy assisted. If you have a friend in an ENT, you can ask him to put a scope and then you can take it out. That's much easier, much more simpler to do. Okay. Things that can happen chairside, what you can see sometimes is soft tissue impregnation that can happen. You can see here on the image on the left, the soft tissue. If the sinus lining, if you have not closed the window, then soft tissue can impregnate into the sinus window and can leave that site open. Yeah, you can have failures like this, lining implant going into the sinus. Then just to take it out. Yeah, while taking out, very important is localize it. So again, you need CBCT to localize it and then take this implant out. So before I conclude, I would like to say that the direct sinus graft procedures, I would just go back and put my yes. Coming back, let's understand that the direct sinus graft procedures are required. As per the study by Ninad and Neil, 50%, 55% of the cases have less bone in the posterior maxilla, and they all would require sinus graft, and that would form a big amount of our population. So it's important that all of us learn sinus augmentation. Some of them would go into an indirect sinus lift case, some would go into a direct, but yes, both of the procedures are important. Secondly, very important to understand that you evaluate the entire sinus, especially the radiographic evaluation is very, very important. You look at the position of the roots. If you are the one who's extracting the teeth, then understand the relationship of the roots to the sinus. That will help you avoid a sinus graft procedure. So if you know that the root is higher and there's a lining that's already dipped, then you do a socket augmentation. So later you don't have to do sinus graft. Okay, so you will plan your extractions well. Secondly, understand there can be pathologies like cysts or thicker lining, so you can understand that and then plan accordingly. The direct sinus graft procedures have to be considered with a certain opinion that there are going to be something called a septae that are going to be present in the sinus, some complete, some incomplete. Sometimes you can use a septae to your advantage. Sometimes if you have a large septae, then you will have to look at bypassing them, because usually while lifting the lining around a septa, having a tear is usually common. I don't say you cannot have a tear, you will end up with a tear and then you need to cover that up. Thirdly, you have to understand there are various graft materials that are available which you can use in the sinus. So I would not say A is better than B, but always having a certain amount of autogenous bone is advantageous, especially in cases where you're doing a two-stage approach. That is, where you're grafting today and then coming down 6 months later and then putting an implant. In those cases, putting a graft into the sinus with some amount of autogenous is always beneficial. It will reduce the rate or reduce the amount of your waiting for re-entry, and that's very, very important. The next is, apart from that, you can use bioactive glasses, you can use xenogenic, allogenic, any material. Most of them would work in the sinus because sinus per se is very, very osteogenic, and that's important. The sinus lining is osteogenic. There are mesenchymal progenitors that can undergo osteoblastic change and then form bone into that area. There's also a school of thought that you can lift the sinus as long as you're ready to keep the membrane away. You can fill the whole thing with a lot of PRF. You can still form bone. But the key is understanding that the implants that you're placing to tent the lining have to be rock solid. Means you need to have at least 3 mm of bone. Then you can probably try and lift the lining without perforating, then pack the whole area with considerable PRF and hope that the entire side gets filled up with bone. That's important, and that's probably in personally I find it a bit unpredictable. Works in some hands, not in all. Uh, so whether to graft or not to graft is a call that you take, but personally, yes, I would say go and graft. Next, whether sinus grafts are successful? Yes, sinus grafting is probably the most successful of all augmentation procedures done in the oral cavity, and they all work very good. Longevity, yes, the sinus grafts do hold volume. There is a considerable reduction in the volume, but the bone volume would eventually end at the tip of the implant, and that's where it would hold up. So augmenting too much is of no use. You will simply waste a lot of money or your patient's money on that. Complications, yes. There are errors that can happen that includes improper assessment of bone height, which would include a certain amount of what we call as where your window has to be made, as you saw in that last video. Secondly, you'll also have to look at whether there's going to be a sinus lining tear. 1 in 4 cases will have a tear, so be prepared to repair those or correct. Apart from that, you can have some infections, so please take care of those. But otherwise, usually the complications are not so high. Outcomes, as I said you, successful, absolutely around 95%, 90 to 95% success of all augmentation cases happens in the sinus. So with that, I would say that direct sinus graft procedures, very, very successful. And I'm pretty sure you all would do very well with those cases that come to your offices. I would probably say, just before I log out, say thank you so much, Isoi, for giving me this opportunity and arranging this wonderful Facebook Live webinar for the benefit of all the members. I hope that people have enjoyed it. I'm ready to take questions. I'll just log out of this. Just before that, I'll put this. We have a Facebook Live session on 31st of March at 11 a.m. by the very talented Varun Acharya. He's going to be speaking on a topic that I dread, perfecting implant occlusion, and I'm looking forward to listening to this. Thank you. Thank you one and all for being a wonderful audience. Thank you so much. Home page. Uh, can I end? One sec. Hello? Hello? Okay. I'll end it now. I'm done. I'll end it now. Okay. Yeah, I'll take that, yes. How do I take the questions? Okay, fine. Okay, I'll do that. Yeah. I'll just see some questions. I'm just trying for that. Just give me a minute. Uh, uh, Dr. Mahajan asks that he's used Tata bone. It's not used. By definition, it's demineralized or mineralized freeze-dried bone allograft. It should work good. I don't find the reason why it should not work. That's what I told. I'm not looking at what material would work or what material would not work. As long as you know the indication, the contraindication, and what it would do, I think any material should work in the sinus. Yash asks Korean surgeon's name Dong Seok Son is a master. Sahil asks how far should be the inferior and the anterior border of the window. The lower border of the window should probably be above the residual bone height, not more than that. If you go a bit higher, then your instrument has to go that much more deeper to separate the lining from the depth. So you're better off being more, not more than 2 millimeters. I think that's what would be. Amol asks, what? Yeah. Would you suggest a trapdoor or take the window? Or that's your call. Depending on the sinus lining. If you're very good with lifting the window, you can always do that. If you think you may end up. See, the idea is to lift the lining and put a graft. So while taking that piece of bone out, in case you end up with a perforation, then it's like very, it's not something very good to have. So I'd rather, if the window shows signs of peeling off very easy, you can take it off. Otherwise you can leave it there. Dr. Rita Singh asks, choice of antibiotics for the sinus graft. Yeah, this is an excellent question. I forgot to cover this. Uh, Post-operatively, my call would be a standard. If a patient is good with Augmentin, then it would be Augmentin 625 twice a day for 7 days, not 5 days. Then along with that, uh, in case the patient is diabetic or something, then probably I would add metronidazole, 400 milligrams thrice a day for 5 days. Okay. Along with that, there would be a certain standard instruction that not to blow your nose, and there'll be always oxymetazoline, and that would be an Otrobin nasal drop, 2 drops each nostril 3 or 4 times a day, so that there's no nasal congestion that you're suffering from. That's what I would look at it. The patient is allergic to penicillins, then I would look at something like ofloxacin and ornodazole, or a plain ofloxacin also should do. But that's what it would. Dr. Ashwini Balarao asks, have I placed dentine graft in the sinus? Unfortunately, no. I've actually just we are actually doing a small clinical trial using dentine grafts in sockets, just very beginning. So let's see how it goes. I'm as of it not. Atul Verma asks, can we have some special sessions for membrane placements and PRF? I think the Isoi would take a call on that. In case of the cyst, why didn't I remove the cystic lining? The cyst was actually on the inner side. Okay, so in my effort to remove the cystic lining, I would probably would end up tearing the whole thing. Why should I leave bother it? It is not going to bother me, so just leave it there. Dr. Pratima asks, would I mix the graft with some antibiotic solution? No, I personally I even do not irrigate the sinus with any antibiotic. Okay, please understand most of these solutions are certain a little bit of acidic in nature, and I would not use any kind of acidic environment on the bone. I would rather just flush it with plain saline if I need to, otherwise nothing. I would actually just keep blood and nothing more than that. So just clean it up, lift your lining, have the blood fill in there and put your graft and be done and dusted with no antibiotics. There are clinicians who flush with a metronidazole irrigation or probably even an augmentin solution, but I personally don't do that. Jay Sinoja asks which company kit is easier. I have no idea. I have not used many, so I'm a bit more old school. I still use or diamond drill. But my primary source of entry into the lateral window would be a piezo. I just love the piezo. That's my way of doing it. Make life much more easier. Please understand, I'm a bit old school. Already 15 years into doing it. Piezo works for me, but you can use the kits. Yes, I want to about PRF grafts. Yeah, you can use PRF as I told you. Uh, Menopausal and osteoporotic women bone appears yellowish. Yes, bone does appear. My would be that I would autogenous. That would do it. Iron supplement, I don't know whether it would help. It would only help in getting a good amount of what we call hemoglobin in the patient. But I don't know if it is going to make the bone red or pink. But yes, you would not operate in any patient who's got a HB percentage of less than 10. That's the first thing. And material for the you just aspirate, it would come. How Dr. Paresh asks, come on, how common is infection in a grafted site? I probably, as of yet, have probably some 3 cases which had an infection in the sinus, and most common thing to have, the reason to have an infection in a grafted sinus site is a pre-existing nasal infection. And I'll tell you, in all those cases, I had been callous. So if you have pre-existing infection, then you can have a graft infection. Second, is if you not used a virgin bottle of bone graft. What I mean is, if you used a graft material that had been open for some time, then you are risking an infection, this one. So always in the sinus, a virgin bottle of bone graft. That's number one. That's what it should happen in it. Second, my protocol would be that you just take the whole thing out. What I do, if I have, in all those cases, one case is still happening right now. I have actually just taken out the entire thing. I'll even rip out the entire sinus lining. Whatever comes out, the whole thing is just taken out, cleansed, flushed with considerable amount of saline. And this is one time when I would use betadine into the sinus. And then after using betadine irrigation into the sinus, I would again flush it with saline, see that there is fresh blood filling into that area, and just leave it there. I wouldn't put a membrane also to close the lateral window. Then a standard antibiotic prescription, then come back 3 months down the line and then re-enter and check. That's what I would do. Yeah, but if I see a sign of infection, my protocol would be to just remove everything that is there. Should I steroid? Yes, you can prescribe to reduce the initial swelling. I normally standard operating protocol is any case which I have placed more than 3 implants, I would normally give 1 injection of DEXA. So that gives the patient a good amount of relief from pain as well as swelling, but nothing more than that. Do you tag the membrane? No, I don't tag the membrane, Mandar. It just folds down, so I don't need to do anything. Abhijit asks, Abhijit Monte asks, to prevent re-pneumatization, what do you mean by re-pneumatization? Shouldn't be an ideal biomaterial combination of auto and a low substitution? Yes. If I am looking at pneumatization of the sinus, if I'm looking at the sinus getting pneumatized, then I would use auto anything material in this one. It's like in a socket, I mean. Okay. Abhishek Kavlekar, are the protocols to deal with patients having acute and chronic sinusitis? Yes, acute sinusitis, avoid, obviously get them well, and then you can always obviously treat them. Chronic sinusitis, chronic sinusitis per se only affects the thickness of the lining. Okay, you pre-medicate them. What I would say is you pre-medicate them 2 days before your scheduled surgery, so that there's no active bacterial this one happening. So what you do is you pre-medicate them, then extend the antibiotics to 7 days. So you're looking at around 9 days of antibiotic course for them. The advantage of patients with chronic sinusitis is they usually end up having excellently thick lining. So that's excellent to have. Protocol of managing sinus perforation, it depends, Vivek, on where the perforation is. If you have perforation at the top, you can just fold it, it will hold up, you can cover the lining. If you have perforation that's on the medial side, that's when it goes tough. Medial or distal of the window is a tough issue because you don't know whether you actually completely lifted the lining or no in that situation. Okay, so sometimes it's better to avoid the site. You can come back and put the redo the lifting 3 months or 6 months down the line. But if you have smaller perforations and you know you are seeing the entire perforation and you're able to lift around the lining around the perforation, then you can always close it off with a nice membrane or a PRF and then go ahead with your grafting as a standard operating procedure. So I would always look at questions coming on the Isoi forum page, and I will obviously take time and then answer all of them. Thank you, everyone. You've been very good, and all of you stay home, stay safe. I'll bide over this time, and then obviously home in your and do a lecture, whereas nice and neat. We can meet friends physically, and that's important. Yeah, I just got a question. Vikas Dheer asks, what is the predictability of the procedure? Predictability, absolutely good. It's probably the most successful of all augmentation procedures. You should re-enter. Re-entry time, if I've used a lot of autogenous bone, would be 4.5 months. If only material, then it would be 8 plus, 6 or 8 plus, not before than that. Your comment about intentional perforation, what do you mean by intentional perforation? Because I think I would close it now. Thank you so much. Thank you.